Hello, good morning, my friends. So myself, Kirtan, I am a final year medical student. Basically, I shouldn't call myself medical student. I have now graduated. So I am from BJ Medical College, Ahmedabad. It's in the state of Gujarat. And I stay in the city of Gandhinagar, which is like the capital of Gujarat. And today, it's quite a rainy weather. So it's almost like 9:30 here, just 2.5 hours before the midnight. And it's so rainy here that I apologize if you can hear lots of noises of rain and disturbances there. And before I pass the mic on to my fellow team members, I just wanted to briefly reflect on yesterday's case. Actually, I was supposed to do the teaching points, but because of bad network and somehow Zoom meeting, tries to auto update while the Zoom meeting is on. So it just crashes every time. So I was not able to complete it, but I would take less than 1 minute for that. So basically, we were dealing with that what can cause the coagulopathy or bleeding in some patient with seemingly normal INR and APTT, because those are the parameters that we usually look for while evaluating the bleeding. So Reza and Ravi beautifully discussed that we have to first look for the platelet count. And in the platelet count, let's say if it is not normal, then we are dealing with quantitative platelet disorder. And if they are normal, then maybe we are dealing with qualitative platelet disorders. So we have to think about the secondary causes of platelet dysfunction, like let's say uremia or stuff like SSRIs, which can interfere with the platelet functions. And if that is not the case, then we can look at the vessel wall pathologies like scurvy is there, amyloid angiopathy, and all other disorders of connective tissues, which can affect the collagen structural framework, which holds the vessel together. Even if that is normal, then we can think about the von Willebrand disease. And as the last category, disorders of fibrinolysis, because fibrinolysis is something which is not there in APDT and INR. They can't measure the level of fibrinolysis. So disorders of fibrinolysis, like let's say excessive level of urokinase or tissue plastrogen activator, can drive the fibrinolysis and cause coagulopathy. And sometimes inhibitors of fibrinolysis, which are not present in adequate amount, let's say antiplasmin deficiency due to cirrhosis, can cause the excessive fibrinolysis, and that can cause bleeding. So that was my reflection from the yesterday's case. And today I will be facilitating, and we are looking for a case. And I believe that we already have a case presenter. So I'm so excited for that. And we appreciate everyone to share their thoughts in the chat. And if you're in a place where you can unmute yourself, then please share your thoughts. But if you can't, then still share your thoughts. We appreciate it. It's all right. And now I would like to pass the mic to Vele and maybe Vele can introduce herself.
Thank you, Kirtan. I'm so excited to hear you facilitate. You're amazing. And your teaching points are always the highlight of the sessions. So yeah, I'm Vale. I'm from Lima, Peru. I will say that here in Lima, we are actually quite cold. But then again, I think we are a country that complains for a little cold, and it's not that cold actually. So yeah, super excited. And I know David has a case. Really great to see someone new in the Global VMR community. Maybe I can pass the mic to Rafa so that he can introduce himself.
Hi everyone, so my name is Rafael and I'm a last year medical school. I'm a medical student here from Brazil. And a fun fact about my city, since Vale was talking about the weather, it's just, I don't know in the other parts of Brazil, but in my city, it's like we have the 4 seasons in one day. It starts very cold and in the end of the day, it's very hot. So in the morning, you go with your like a very specific kind of clothes, and then in the evening, oh my God. So that's just a fun fact to share here in Brazil. So maybe Danny can go next, please.
Hi, everyone. My name is Daniela. I'm also a medical student from Brazil. And here in my city of the very large country that me and Rafa live in, it's either very hot and with rain on some parts of the day, or very hot and with rain all day. And yeah, one of these days we had, I don't know how to say this in English, but ice fell from the sky. So that was very funny because we are usually used to very high temperatures. And was missing? Granizo. What's missing to go now? Granizada.
I think I can go next.
Yeah, go ahead, Franco. Sorry.
Yeah. Hi, everybody. I'm Franco. I'm doing scribing today. I'm actually from Cusco, Peru right now, but right now I am in Lima. And I'm really excited because I am going to Cusco on Wednesday because of my little sister's birthday. I will go to my hometown for quite a few times. So I think that I can pass the mic to Kirtan again, so you can pass the mic to anyone else.
Yes, Ravi. So do you have to share some thoughts before we ask the Hernandez to share the case?
I'll just say a quick hello and excited for David's case. It should be a lot of fun. I am calling in from San Francisco, but you'll notice the background is a little different. I'm calling you from a dog park where all these cute little dogs are running around and playing. It's honestly the best thing in the world sometimes because dogs show you how simple life is. They could literally spend all day here just running around and playing with each other. And sometimes they get into arguments, but if you keep them apart for 2 or 3 minutes, they forget. So my ultimate sort of life wisdom in the last 24 hours has been watching this show on Apple TV called Ted Lasso. I'm not sure if you guys or folks have heard of it. It's so good. And he says the following lines. You know what the best animal is? And the player says, what? He says, a goldfish. And then he says, why? It has a memory of 10 seconds. Go live your life like you have a memory of 10 seconds, which if you're in medicine is a horrible thing to have because you take care of your patients. But if you're in life, I think sometimes it's good to have a memory of just 10 seconds. So Kirtan, please don't take my advice for the facilitation, but maybe for the rest of life, it comes in handy.
Thank you so much for sharing that funny fact, Ravi. So David, whenever you are ready, we can start, and we can start with the chief complaint first.
Yes, I'm ready. First of all, I would like to introduce myself. I'm David. David. I am a fourth-year medical student at Brown University. I am applying into internal medicine pretty soon. I'm really excited to be here and to be part of this community. I'm excited to share this case with all of you. So the chief complaint, we have a 50-year-old female who presented to the hospital with 3 days of abdominal pain and diarrhea.
All right. And do you think, David, this is a good place to stop?
I can give you information about the HPI so you can have more information to think about.
Yes, sure.
Okay. So the patient was in her usual state of health until Sunday when she developed diarrhea. The diarrhea kept progressing, which prompted her to go to the emergency room on a Tuesday. Initially, she had 10 episodes of diarrhea on Monday and then 5 more Tuesday before going to the hospital. She described the diarrhea as non-bloody and cramping 10 out of 10 in pain severity. Pertinent negative findings were no fever, no shortness of breath, no chest pain, nausea or vomit, and no recent contacts. Significant positives include a recent travel to New York City, particularly Queens, New York, where she had some traditional Ecuadorian food. She also completed a course of Keflex for a UTI 3 days prior to the onset of her symptoms, and she endorsed chills and abdominal pain. I think that's the HPI. I have another aliquot with a little bit more past medical history and all medical, family, social. But
I think this is a good place to stop, David. Thank you so much for sharing that data. Yeah.
Perfect.
Sure. So first of all, we have to worry about the case, whether we are dealing with infectious cause or whether we are dealing with non-infectious cause, and whether we are dealing with some sinister pathology or not. And in the chat, I can see some very nice thoughts. So Harshil, do you mind unmuting yourself and share your thoughts? And I guess I am seeing you for the first time. So do you mind introducing yourself a bit? And then maybe share what are your thoughts on food poisoning and related to abdominal pain and diarrhea?
Sure, sure. Thank you so much for the opportunity. So, my name is Harshil, and I'm from Bowel. I'm a fourth-year medical student at Hello, am I audible?
Yes, yes.
Yeah, hello, myself Dr. Harshil Shah. I am MD Medicine, passed out in 2020 from PDU Medical College, Rajkot in Gujarat state from India.
Sure.
As we have very much issues about water and food, so usually we keep on the first possibility of water or food-induced diarrhea, that is usually infective causes. Initially, it is food poisoning, which is very common. If it is occurs up to within 12 hours, then Bacillus cereus is very common etiology. If more than that, then again, if having fever more than 7 days, then possibility of Salmonella, Shigella is there. As age is 50-year, possibility of irritable bowel syndrome is also that, but the patient present with the first week, first time, so chances of irritable bowel syndrome or inflammatory bowel disease is less likely. As there is no fever, usually patient having diarrhea with dehydration, possibility of cramps and abdominal pain, that is because of diarrhea. So the frequency of diarrhea, whether after taking ORS, patient having improvement of the symptoms or not, that is very important. Usually, drug-induced diarrhea, which is very common because of loss of cilia and in the mucosa, and that damages to the intestinal wall.
Sure, Harshil, thanks for that approach. I really love the irritable bowel syndrome part because it is a diagnosis which is very hard to capture. And thank you for sharing your thoughts regarding that. And I just saw Ravi, put the glasses like James Bond. So Ravi, what are you doing there?
I can't tell if you're saying me or Ravi.
No, you only.
No, me. I dented my. Well, one, it's really nice to meet you, Harshil. I think this is the first time I'm hearing your voice, and two, my dog dented my glasses. Look, so I'm trying to fix them. That's it.
Yes. And so another interesting thought that came up in the chat was by Sarah, that how stress and anxiety can also lead to diarrhea and abdominal pain. So Sarah, that's a really interesting thoughts and a novel way of approaching this complaint. So do you mind unmuting yourself and share your thoughts regarding that?
Sure. I think that sometimes when the patient has an acute case of diarrhea and abdominal pain can really be can relate to symptoms like, because generally when I see a patient like this that has no history before that of abdominal pain or any gastrointestinal symptoms, I think that our head can really cause effects in our gastrointestinal. I'm sorry, I get so nervous speaking in public, so
You are doing great. You are doing great, Sarah.
I'm from Brazil, so I get very nervous speaking English, but I hope I can actually say something. But it's because since it's a 50-year-old person, like maybe she's feeling some, I don't know how the history is doing of her. Like I know that this can lead to 1,000 symptoms, but I think that the way that we deal with stuff can also, can I say in Portuguese just real quick because I just saw something.
Sure, please.
I know that Dani is from the same city as me, so maybe she can understand better than me. But Dani, if you listen to it, please translate after. But acho que tudo que, assim, vários sintomas abdominais são muito relacionados com o nosso psicológico. Então, pelo menos o que eu vejo muito em pessoas mais idosas é que isso fica muito relacionado com doenças psicológicas, depressão, ansiedade, e isso tem um efeito direto com sintomas abdominais. Dani, if you can please.
Yeah. So basically, I think you said it beautifully before even saying it in Portuguese, but so basically trying to translate what Sarah said, it's especially in this age, patients who have symptoms of abdominal pain or any abdominal symptoms, it is most likely related to psychological causes. And now I'll add in a word that you didn't use, but I think is very fitting, which is the somatization of everything that the person is feeling and having it present on the body, and most likely abdominal pain or any other symptoms like that.
Thanks for sharing that. And Tara, I didn't understand what you said, but it was so pleasing to hear. So please thank you for sharing your thoughts in Portuguese. And thank you for translating that, Daniela. And I think before we move forward, one of the chats, one of the things which I saw in chat was that Ravi Singh mentioned that how we can link the history of UTI and the antibiotics to our symptoms. So Ravi, do you mind unmuting yourself and tell us that how antibiotics can be a clue to underlying cause in this scenario?
कीर्तन कैसे हो?
अरे बढ़िया हूँ, thank you.
Acha, yeah, one thing that I see with urinary tract infections commonly presenting to the hospital, we do have associated diarrhea. Sometimes the inflammation can be a noisy neighbor and can, move on to the intestine and cause possibly diarrhea. I've also seen the opposite, where the inflammation could cause like a paralytic ileus. So it can manifest with either diarrhea or it could be constipation. But there's interesting with the 3 days of antibiotics. I was just wondering, it's kind of soon for the patient to have manifest with C. diff, which we see it's always a knee-jerk sort of a diagnosis that we make with any use of antibiotics. But there is an entity called antibiotic-induced diarrhea, which can happen, which is kind of benign. It won't be malignant, and I don't think it would cause this amount of abdominal pain. But I do want a bit more information to see if this is something in the inflammatory or non-inflammatory, and the inflammatory could be anything like infectious and so on. So that's all I had to say about that.
Yes, thanks for sharing that thought. I really like the antibiotic part and the C. diff part. And in fact, if we focus on the severe abdominal part, then it really raises the concern, because usually gastroenteritis don't tend to cause severe abdominal pain. And if we are indeed thinking about C. diff colitis because of antibiotics, then we know that C. diff can cause toxic megacolon kind of pathology. So it would be really interesting to see the bowel sounds. I mean, what kind of bowel sounds we perceive on physical examination, whether the abdomen is distended or not. And I'm also worried about the peritonitis kind of thing, because the severe abdominal pain is so unusual. And of course, we can think about the mesenteric vascular problem. And usually it tends to cause bloody diarrhea, things like ischemic colitis or mesenteric vasculitis kind of stuff, but it won't cause the watery diarrhea. So I think the pearl that you mentioned, that how antibiotic can cause C. diff and that may have led to toxic megacolon, is really interesting and fascinating. And now, David, do you mind giving us physical examination, and maybe in next report we can handle a bit of labs?
Yes, of course. I realize that abdominal pain is a very broad chief complaint, and I think you have approached it very well. I can definitely give you vitals and physical exam. I have some other past medical history, medication, family social history to share. Would you like me to give you that too, or move on to vitals and physical exam?
No. Please give us other vital part of the past medical history, family history, and then we can move on to the physical examination.
Okay, and I will keep it very pertinent to our case. So, significant past medical history for H. pylori infection in 2019 without any ulcers and no record of treatment, and history of GERD. Medication that she's taking, significant for our case, include omeprazole. As far as family history is non-contributory. Social history, I think it's contributory because she's from Ecuador, and as I said, but she has lived in the US for 20 years. Recently, prior to the presentation, went to Queens, New York to have some food. No smoking, no alcohol history, no drug consumption. Okay. So now moving on to the vitals. These vitals were obtained in the emergency department when she arrived. She had a temperature of 97.9 Fahrenheit, which is 36.6 Celsius, heart rate of 84. blood pressure of 126/82, respiratory rate of 20, and she had an oxygen saturation of 97% and room air. Okay, so on physical exam, general appearance, she was non-toxic, non-diaphoretic, conjunctiva were normal. She had a normal heart rate and rhythm. And she was in no respiratory distress with normal breath sounds. Abdominal exam revealed lower abdominal tenderness with hyperactive bowel sounds. There was no costovertebral angle tenderness. Her skin was warm and dry. She had no lower extremity or upper extremity edema and no neurological deficits. So I can also share some initial imaging and labs. I do have to say that the labs in this case are very important, and I have labs from the time she first arrived in the emergency room, then labs 10 days into her hospital stay, and then labs following prior to discharge.
Yes, David, it would be perfect if you can give us initial labs, and then maybe we can look into the subsequent labs and imaging studies.
Perfect. So I will give you pertinent labs. A BUN of 7, creatinine of 0.62, sodium of 135, white blood cell count of 7.8, hemoglobin of 12.6, and platelets of 241. CRP was 5.5, ESR 23. She had a C. diff test, which was negative, and she had a stool Kerry-Blair test, which came back positive for Shiga-like toxin producing E. coli and enteroaggregative E. coli. So even though she said that the bloody was, that the diarrhea was non-bloody, on exam, the evaluation did reveal that there was blood in her diarrhea. And finally, she had a CT of the abdomen and pelvis, which revealed pancolitis of uncertain etiology.
Sure. Thank you so much for sharing that, David. And I think we have cleared many doubts that we had before. And I think before I appreciate the comments in the chat, maybe I would like to pass the mic to Ravi and tell us that how we approach the situations in such case when we have a pathogen at our hand, but we have to explain that how it can cause severe abdominal pain and certain lab findings which might not best fit with it. So Ravi, can you help us?
My pleasure, always. I have to say, I commend you for focusing on the abdominal pain instead of focusing on the diarrhea, because it is unfair to expect the colon to work well when the patient is sick. If you ever think about when any of you had even a mild cold, your bowel habits change. Your colon is designed to work well when you are well. And no matter what, you will have a change in your bowel habits when you are unwell. So diarrhea in the face of a systemic illness does not have any value, except when it becomes dominant. And here, David has shown us that the diarrhea is dominant because it's bloody. Bloody diarrhea is not a normal change in bowel habit expected with illness. And so the question I think Kirtan is wondering is, what does the fact that we have found something in the stool, how does that help us understand the current syndrome? And this is an important topic because the principle about which I will share with you is the following. When a test is so good, like PCR, when it's so good, it can be unhelpful. So when you get when there are many ways to test stool, you can test stool through culture, and you can test stool through antigen, and you can test stool through PCR. Culture is fairly insensitive because it requires a high degree of organism to be present. PCR is unbelievably, ridiculously good at its sensitivity, and the problem is it can catch a colonizer. 15% of us will have C. diff in our bowel right now, and it won't be causing any problems. And that same principle can apply to many organisms. So the question here is this Shiga toxin producing E. coli a colonizer detected only because the test that we used is so good, or is it a pathogen? And that's when we have to marry it with the clinical syndrome. Does Shiga toxin account for colitis in this patient? Very possibly. But I'll leave you to analyze it, but we're not home free. Just because a PCR is positive does not mean it is causing the problem, because PCR is very good.
Yes, thank you so much for telling us that how we have to interpret the labs in a nice manner and a sensible manner. So even I was thinking about this, that colitis can be due to Shigella, but there are other pathogens which we may not have caught on the PCR thing. So what if the patient has, got a parasite there? So things like schistosomiasis or strongyloidiasis can cause colitis. And last thing that I would like to mention is that sometimes we have colitis, but we also have to worry about the complications arising from it. So the whole colon is inflamed. What if there is some evidence of hepatic abscess or splenic abscess or something like septic thrombophlebitis, like portal vein thrombophlebitis, which can be causing showers of emboli of infectious disease everywhere and can be accounting for the sinister symptoms. So that's what I was thinking about. And in the chat, I can see my old and dear friend Dhruv here. So Dhruv, can you share us thoughts, like what are you thinking about the Shiga toxin and how we can link it to diarrhea?
So two things. First, hi everyone. One, usually when I think of Shiga toxin and E. coli that produce that, or well, Shiga toxin from Shigella or E. coli that produce Shiga-like toxin, so enterohemorrhagic E. coli, I think of bloody diarrhea, which this patient does not have. So that makes me think, that it's unlikely that it was enterohemorrhagic E. coli that could be doing it, although you could still have an enterohemorrhagic E. coli that could cause non-bloody diarrhea. The second thing, and this is a question that I would like to ask David, is on the white blood count, what is the differential? As in how many neutrophils, lymphocytes, macrophages, eosinophils are there in that 7,800 white blood cells per microliter? Because if that white count has a differential that's anything other than neutrophil predominant, then that can give us a clue. Especially if it's eosinophil predominant, then we may go down the route of, say, parasites, for instance, which, given that this patient has had recent travel and recent ingestion of food that was prepared in a way that's not necessarily conventional, may indicate parasitic infection.
Yes, I think that excellent point, that we have to be aware of the differential on the WBC. And before we move on to the next aliquot, I would just like to pass the mic to Kushal, who is like infectious disease expert. And I apologize for not bringing him up until this late in the case. And maybe he can share vital insights on the history of Ecuador and all this abdominal pain that we already have Shiga toxin positive in the PCR. So now how to approach this, Kushal?
Thank you for the kind words, Kirtan. Sorry if I joined the case late, so I'm trying to catch up on the history and labs and everything so far. So I think Ravi has already mentioned all the good points. Only thing I would like to add is I was wondering what kind of food the patient ate for Ecuadorian cuisine. if the patient ate something with salad in it, with raspberries, basil, it can be a risk factor for cyclospora. If there is pork intestine in the diet, it can cause Yersinia colitis. And if the patient swims a lot in community swimming pools, Cryptosporidium and Giardia can be in the differentials because those are the organisms that don't get killed by chlorine. Yeah, that's all I can think of right now. But I agree with Rabi that since the PCR sensitivity is so high, we shouldn't be anchoring our diagnosis on Shiga toxin or enteroaggregated E. coli as of right now.
Yes, thank you so much for sharing those reflections, Kushal. And maybe now I can request David to give us some more labs and the hospital course of the patient.
Yes, of course, those were wonderful interventions. So to answer everyone's questions, while in New York, our patient had soup fish. She later had coconut water and also ate the coconut meat. And she had a juice made with milk as opposed to water. As far as the white blood cell differential, she had a sex of 9.2, lymphs of 0.8, and monocytes of 1.1. Okay, so important for our hospital course are the labs. So 10 days into her hospital course, we have a patient with a hemoglobin of 5.9, platelets of 35, creatinine of 8.4, BUN of 88. Should I repeat? I'm sorry, I don't know if I'm going too fast. I can go again.
Yes, yes, that would be perfect if you can just repeat the last few
Yes,
labs.
of course, they are very important. Hemoglobin of 5.9, platelets of 35, creatinine of 8.4, BUN of 88, sodium 124, and her white blood cell count increased to 11.1. In the setting of her lab changes, we have some additional lab work just to try to figure out where the anemia was coming from. So we had an LDH of 1712. Haptoglobin was less than 8. A D-dimer of 1998. So I'll give you this information right now. I have a couple more labs, but maybe we can have some discussion as to what people think at this point, and then I can add some more information.
Yes. Sure.
Let me know if you would like me to repeat any of the labs. I know I mentioned quite a few.
Yes. So David, just a little bit of clarifying that I wanted to need that the LDH of 7.1, is that elevated as per your laboratory standards?
The LDH was 1712.
Definitely.
And the haptoglobin was less than 8. And the D-dimer was 1998. 1998.
Yes. Thank you so much for clarifying those doubts, David. And I think what we were discussing few minutes ago, that although we have cytotoxin at hand, we have to worry about the possible complications arising from it. And now we have the evidence. Previously, we had no evidence of hemolysis or renal dysfunction, but now we have classic evidence of microangiopathic hemolytic anemia along with thrombocytopenia and renal failure. So we are, looking down at the barrel for hemolytic uremic syndrome, but still we need to get peripheral smear to look at the cystocytes. And I saw in the chat that Dr. Kasojis is here, and she has some really nice thoughts regarding this. So Dr. Kasojis, do you mind unmuting yourself and share your thoughts regarding Shigella causing hemolytic uremic syndrome?
Yes, hello, can you hear me?
Yes, we can hear you.
Okay, great. Sorry, my video's off just because I'm kind of moving between places. Yeah, I mean, thank you so far for this session. Thank you for allowing me in this space. This is a great case. Once we saw those labs, I kind of pivoted towards, I knew this was infectious. I was thinking, of course, of an organism of some sort, just because this is an acute onset. As you guys probably know, that diarrhea, sort of in my head, how I approach it is this acute or chronic, but clearly this is an acute manifestation of the diarrhea, but also the abdominal pain. But the labs sort of give us a window into, okay, her labs were okay at the beginning, and now we can see the hemoglobin went down, platelets went down. And then once we got the LDH and the haptoglobin and we see that D-dimer, I mean, those are just, crazy numbers. And so it's like an alarm in my head going, okay, I know this is infectious. What organism do I know causes this kind of picture where you see this renal dysfunction, this thrombocytopenia and anemia? And one of those is, you can't miss, is the Shigella-like toxin, which is usually found in strains of E. coli or Shigella species. And so I think that's the route we sort of have to think about. Clearly, this lady is very unstable, so we got to make sure we stabilize her as well. So that's sort of where my thoughts are. Thank you.
Yes, definitely. Thank you so much for sharing your thoughts, Dr. Kasoji. We appreciate it. Now, before we move ahead, I think Jasimran had some nice thought. So Jasimran, do you mind unmuting yourself and sharing your thoughts?
Oh, Kirtan, I was just mentioning, like, whenever we used to read about HUS and TTP, so it's like HUS is more common in younger age. So it's like, I don't know, like if in clinical practice, we see it in more elderly group or like the middle age, but what we used to see, it's more common, like they are more prone to get the diarrhea, and the HUS is more common in younger age. That's what I wanted to say. And the other thing that fits here, like, is everything, it's on the screen, I think. The hemolysis, the diarrhea, the fever, I think the triads is fitting for the HUS. So that's all.
Sure. And what I can say is that before we conclude that disease, let's say HUS or MAHA, like microangiopathic hemolytic anemia, it is imperative that we look at the peripheral smear, because sometimes we may think that it is actually hemolysis, but what if we are not dealing with microangiopathic hemolytic anemia? So peripheral smear is very important in this case. And David, do you think that we can move ahead and get some next steps before moving to the final report?
Peripheral smear, these show schistocytes. At this point, yes, you are all correct. This is a case of HUS, which also does present more commonly in children, but as we all just learned, it can present in adults. In our differential, we had typical versus atypical HUS, and the three labs that I was keeping from you all were the C3 complement, C4 complement. C3 complement was 122, C4 complement was 16. And finally, on the differential is also TTP. And we also tested her for Adams T13. Unfortunately, this is a test that takes a long time to come back, more than 5 days. In this case, it did not come back while she was in the hospital. But I have the answer for you, which is 70%. So typically, we would see TTP with Adams T13 less than 10%. So she is within normal limits. At this point, I just have hospital course to share and also learning points, because this is just to discuss the management, what we did for her, and what are the options, because this was a case that was quite multidisciplinary with experts from nephrology, hematology, and also infectious disease and the primary medical team.
Yes, David, if you don't mind, can we discuss a little bit of the data that you gave us, and then maybe after that you can give us the hospital course and what are the take-away messages from this case? Does that sound all right?
Yes, of course.
Sure. So I guess we now have C3 levels and C4 levels, which are a little bit surprising. And I think we have to incorporate that in our illness script. So again, we go back to Rabi, who has like answers for everything. So Rabi, can you tell us that how we have to incorporate C3 and C4 in our illness script in this case?
My pleasure. David, what a absolutely humbling case. I'm really enjoying the discussion and I'm taking a lot of notes along the way. Since you handed me the mic, my friend, it's hard for me to relinquish it. And before I reflect on your question, which I think is a very important one, I wanted to share a piece of advice. So you all were in this world before David was kind enough to make our dilemma easier by giving us the smear. And this world is the combination of anemia and thrombocytopenia. And you'll see that everyone, including me, was like, anemia, thrombocytopenia, microangiopathic hemolytic anemia. That is correct. And that is good training by all of our teachers because that's what we should think. But remember that if you are doing that, you're making the assumption that the anemia and thrombocytopenia are a result of the same mechanism. More commonly, the combination of anemia and thrombocytopenia reflects this phenomenon. You have thrombocytopenia and you have a lesion, so you bleed. And your anemia is from blood loss and your thrombocytopenia is from a reason you have to explain. Of course, a problem in the environment like MAHA is very common, but know that there are other things that can do it, like antibody-mediated autoimmune hemolytic anemia and autoimmune thrombocytopenia, and as can infections. But of course, in the face of the diarrheal illness, you're going to prioritize this, but make sure you prioritize it and look for the smear, because if the smear showed no cystocytes, you might have to go back and revisit your hypothesis. But of course, the smear showed cystocytes, and you were in the world of hemolytic uremic syndrome, which ultimately, I'll show you this table, is a complement problem. All hemolytic uremic syndrome is an excess of the classical complement pathway. And the question is it a result of too much complement generation, which is much more common, 80%, usually from Shiga toxin producing organisms, which as Jasimran pointed out, is usually E. coli and Shigella in young people, but Streptococcus pneumoniae in older people can also produce Shiga toxin. And less commonly, it is because of a deficit in the ability to clear complement, not generate it. And so the lack of clearance causes complement to accumulate and cause damage. And that is atypical HUS. So ultimately, the role of complements in the analysis of hemolytic uremic syndrome is to provides a little bit of support to the idea that you're dealing with a complement-mediated microangiopathic hemolytic anemia, which is basically the definition of hemolytic uremic syndrome, unlike TTP, which is an ADAMS TS13-mediated microangiopathic hemolytic anemia. But based on his nodding, I suspect David has a little bit of reflections and teaching on this. So I'll leave it at there, but I'll say that anemia and thrombocytopenia equals MAHA until proven otherwise. But there are some other things. Most common is thrombocytopenia begetting blood loss anemia. And most important, of course, is a MAHA. And then HUS is complement-mediated microangiopathic hemolytic anemia that results from excessive complement-mediated blood vessel damage, either as a result of a driver of complement consumption or a deficiency in clearing it. And in most people, 80%, is because there's something that's demanding more complement generation, Shiga toxin being a good example. Alrighty, Kirtan, back to you, my friend.
Yes, thank you so much for sharing the thoughts. And I still remember that on one of the VMRs, I learned that, of course, when we have infection, we immediately jump to the HUS, but we have to understand the fact that those people who actually have AHUS, that is atypical hemolytic uremic syndrome, don't just start hemolyzing all of a sudden. You need to have a trigger, and actually infection is that trigger. So like infection can cause HUS as well as AHUS at the same time. So really interesting thought. And now, David, please tell us, amaze us that what were your thinking during this case and what are your takeaway messages?
Okay, great. So big messages, hospital course, and some learning. As I mentioned, this was a multidisciplinary case, so nephrology experts were consulted. Our patient became oliguric with a urine output as low as 120 milliliters per day, which met the criteria for oliguria of less than 400 milliliters per day. In addition to that, she had a tremendous increase in BUN and creatinine over a very short period of time. So she required dialysis. She had 6 sessions in total. And this was not a surprise because up to 50% of patients with HUS will require dialysis. When she was discharged, she was set up with services to continue dialysis outpatient. We also, the nephrology experts, restricted her fluids in the setting of her hyponatremia, which went down to 121 over the course of her hospital stay. And all her medications were renally dosed. The hematology experts were also consulted. And towards the end of her hospital stay, she had already required 5 units of blood transfused, 1 unit of packed platelets. And we believe that the anemia towards the end was multifactorial. Number 1, from the toxin itself, which is anticipated to clear after about 10 days, but for her, it remained for much longer. In addition to that, she had daily phlebotomy. There was mechanical destruction of red blood cells from dialysis, and she did have a period of menstruation during her hospital stay. She did not require plasma exchange therapy during her hospital stay. In fact, HUS is a condition that you treat more symptomatically. Plasma exchange would be for things like TTP. And she continued with outpatient follow-up with hematology and oncology. So other things that the primary team did for her was just check her fluid status, electrolytes, acid base, blood vitals, and things like that. Finally, my teaching point is, which we have already discussed a little bit, is the difference between typical and atypical. Typical being a diarrhea positive HUS, and atypical more consistent with complement mediated HUS. So a treatment that we thought about and that is available for complement mediated HUS is eculizumab. This is a monoclonal antibody that is used, and basically it blocks the complement system and prevents the formation of C5a and the MAC process. This was not used for our patient because hers was more consistent with typical HUS. But a learning point from this is that whenever you are considering this medication for someone, you need to vaccinate them with or against the encapsulated bacteria, such as meningococcal with the meningococcal vaccine, pneumococcal, and H flu. We did vaccinate her against meningococcal, but honestly, we did not think about this as a treatment for her. I understand many of you are coming from areas in which resources are limited, and prior to the development of eculizumab, plasma exchange therapy was the medication to go. Even today, in the absence of eculizumab, plasma exchange is the way to go in atypical HUS cases. So there was no role for plasma exchange in her. Finally, even though the Adams T13 test did not come back during her hospital admission, it did not prevent us from treating. even if you expect that someone or even if you suspect that someone has TTP, you will still treat. You don't wait for an Adams T13 to come back because it just takes a few days. So you treat with plasmapheresis, not consistent with her presentation. So this was definitely a very humbling case in someone who came in with quite a normal kidney function, normal hemoglobin, platelet count. Went to have have fun in New York. It is still unclear what the actual trigger was, but we often learn that poorly cooked beef can trigger HUS and in the setting of Shiga toxin, but there is more to that. Unpasteurized milk can also cause it, and many other types of foods. So yeah, that's all I basically wanted to share. Do you have any questions? Any of you have any questions? Anything else I can provide?
Yes. Yes, not at all, David. I think you explained everything so lucidly and nicely that there are no questions left. You understood the pathophysiology. You explained to us the pathophysiology and how you dealt with these dilemmic scenarios, like whether we're dealing with HUS, AHUS, whether to give eculizumab or not. So awesome thinking points there. And very briefly, I wanted to mention that recently, Rabi and Reza have ignited my interest in pathophysiology by causing the new series on Patreon, RLR Basics. So I just wanted to mention one brief point that whenever we deal with complement levels and one of the complement levels is so disproportionately low to another one, then we have to think about the atypical causes. So things like AHUS and things like C3 glomerulonephritis, which is basically MPGN type 2, that is membranoproliferative glomerulonephritis type 2. In both of these disorders, we have mutations in complement factor H, complement factor U, or complement factor I, as the Rabi showed us in his by sharing his screen a few moments ago. So there have been cases in which a patient can get both of those entities simultaneously. That is, the patient can get C3 glomerulonephritis as well as AHUS because the defect is the same. Defect is in the complement regulation because of the defective complement factor H or complement factor I. So it is very interesting that how by analyzing the C3 and C4 levels, we can move to that. And usually in AHUS, the C3 is disproportionately low rather than C4. In our case, the C4 was disproportionately low. So maybe a little bit away from AHUS. And that's why HUS was more appropriate diagnosis. And I think I have rambled enough now. Now, please take us home, my dear friend Rafa. What are your teaching points from this case?
So first, thank you, David, for the case. A really, really interesting one. And thank you, Kirtan, for facilitating. Incredible as usual. So I'll try to be as brief as possible. So we started this case with abdominal pain and diarrhea for 3 days. And Rabi always teaches us that few causes are identified actually by the physical exam. For example, if we see a rash, we could think about zoster, or we can rely on the labs, for example, in the setting of TKA. But most diagnoses actually rely on a CT exam. And then when we try to combine abdominal pain with diarrhea, we could think about many causes, including, for example, appendicitis, psychological causes, UTI, lactose intolerance. But then we saw that this patient actually had omeprazole and a recent antibiotic use. And we thought about C. diff colitis. And then this is a very important thing to consider because C. diff can actually lead to blood diarrhea in the setting of toxic megacolon. And then I saw that this patient, besides the bloody diarrhea, which can have many causes as well, this patient had anemia and thrombocytopenia on the labs. And then first we have to rule out other causes besides MAHA, for example, splenomegaly, active bleeding or infection, for example, malaria and babesia. And then when we think about microangiopathic hemolytic anemia, there are like this association of low hemoglobin with increased LDH due to the hemolysis with low haptoglobin, but also low platelets due to the consumption of the platelets, and also the blood smear with schistocytes. But then we have to remember that MAHA have many causes that could lead to that. For example, Shiga-like toxin in the set of HUS, TTP, HELP, which is seen in pregnant patients, which is a form of preeclampsia, and then GIC, but GIC is the only one who actually leads to prolonged PT and PTT because there is a consumption of clotting factors. And then HUS, which was the final diagnosis, hemolytic uremic syndrome, is actually commonly caused by the Shiga-like toxin from the enterohemorrhagic E. coli. The serotype that we have to remember is O157H7, and then we have to remember the atypical form, which is actually due to decreased complement clearance from the complement gene mutations or autoimmune response. So thank you, everyone. I hope everyone had a great time, and I hope to see everyone tomorrow.